real life.
Thank you. Thank you, Rishi. Good evening, all. Today we are starting some exam-oriented webinars for all the spine fellows and registrars and residents. Basically, the format is going to be 10 sessions every Friday, 8 to 10 p.m. This is an initiative by VR Spine Learnings. Basically, we are trying to incorporate as many sessions as possible. So we are going to have 5 long cases, 5 short cases, 3 lecture series of scoliosis, because it's a topic which many people wants a little bit of more clarity. And we'll have 2 sessions on tables, which are going to be basic sessions as an exam pattern. We're very, very thankful for OrthoTV for hosting us here. The schedule is in front of you. So we are going to have 5 long cases, 5 short cases, and a couple of lectures. Today's session is basically a long case. We have an eminent faculty with us. Professor Sarat Chandra from AIIMS, New Delhi, is a neurosurgeon, a very well-known academician. I don't need to give any more details about him. He has n number of papers published. Couple of his topic of interest is C1, C2. He has his one DCR method is very common, which is associated with his name. And he's also well known for his epilepsy surgeries in children. And we have Dr. Abhay Nene, my mentor, my guide, and a very charismatic spine surgeon from Mumbai. And Dr. Agnivesh Tikoo, as I said, a fantastic spine surgeon, a senior to me in the unit, and he's wonderful. And he's working at Apollo, Navi Mumbai. Today's presenter is Subhanshu Bhaladhare. He's our exiting ASI fellow. And Dr. Priyank Patel and I will be moderating the session. So without further ado, I think we should start the session. Subhanshu, you can load your slides, please. I'll stop sharing.
Yes. So this will be a real life case presentation format where it's a free for all. So there's one guy on the dock and everyone else can get in, and including other participants can ask questions. And the idea is to make you confident to speak in front of examiners. Yes, Subhanshu, over to you.
Good evening, sir. I'm Dr. Subhanshu Bhaladhare. I'm presenting today a case in which 71-year-old male who is retired a mechanic, right-hand dominant, sick by religion and residing in Mumbai, comes with a chief complaint of clumsiness in upper limb since 6 months, left upper limb weakness since 4 months, difficulty in walking since 3 months, and lower limb weakness since 3 months. On history of presenting illness, patient was apparently all right 6 months back when he first developed clumsiness in upper limb, which was insidious in onset, gradually progressive, associated with difficulty in buttoning and unbuttoning of shirts, followed by gradual noticeable weakness associated with difficulty in holding objects, breaking chapatis, and change in handwriting since last 4 months. History of difficulty in doing overhead activities with left arm like combing hair since last 2 months. There is no associated upper limb radiating pain or tingling. We also give history of difficulty in walking since last 3 months, which was insidious in onset, gradually progressive. Initially, difficulty in walking on uneven surfaces, difficulty in holding chappals, and which worsen over time to difficulty in climbing upstairs and downstairs with holding rails, difficulty in wearing pants, difficulty in getting up from squatting or from chair. Is also not associated with any lower limb pain. There is a history of fall 3 to 4.
What about upper limb pain, Subhanshu? Any upper limb pain?
No, sir. No upper limb pain, sir.
And is religion important here? Personally, I would say don't include that in your introduction of the gentleman.
I would agree with that, sir. There is, unless there is a specific point you want to make for something, like you want to highlight a consanguineous marriage or something, it is better to avoid.
Yeah.
So, but certain neuro illnesses are common in few ethnicities, so should not be just included as a part of protocol?
I would say no, because it's right now the environment is too difficult to, it'll just spark off an unnecessary discussion.
Okay.
Unless there's something very specific, positive, like Agnivesh said, I think I would say no. Go ahead.
Carry on, Subhanshu. Yeah.
There is a history of fall 3 to 4 times due to loss of balance while walking. History of tendency to fall while walking in dark and when washing face. Patient felt difficulty to appreciate the clothes he wear over chest and abdomen, and hot and cold sensation while taking bath. On inquiring, numbness below shoulder and neck was present. There is a history of tightness over both upper limb and lower limb. There is no history of urgency, hesitancy, increased frequency, nocturia, incomplete avoidance, incontinence, or dribbling of urine.
So what does that signify, Subhanshu? Can you go back to the last slide?
Yes.
Yeah. He's having tendency to fall while walking in dark and washing his faces.
Sir, it signifies that there is some kind of sensory ataxia. As soon as there is no sensory input, patient find it difficult to maintain the balance. This is one of the feature of compressive myelopathies.
But that could be in vestibular ataxia also. If you don't have a fixation point, the patient will tend to have dizziness and imbalance. So I think that this point you should sort of you should not land yourself into trouble where examiner gets to ask you questions which you find. So, and while washing face, again, it is something which I don't know has any relevance or not, because are you trying to say instability? Are you trying to sort of mention instability or something by washing face?
Okay.
Yeah, I think it can be there, because washing face is a very important sign. It's called as a wash basin sign. So people who have posterior column involvement, so when they wash their faces, there is a history that they could fall, they could lose their balance. And in fact, some of the posterior column diseases, that's how it's noticed first, especially vitamin B12 deficiencies. One of the commonest way you notice it is that they say that when they're washing the face, they suddenly collapse.
Okay. Sir, can this be a point which differentiate between cerebellar ataxia versus myelopathy?
No, he is very specifically as mentioned. He says history of tendency to fall while walking in the dark.
Yeah.
So he's specifically mentioning posterior columns. So I think it's a relevant point. It should be there. And while washing face, falling down is a described clinical science and literature. So that is also a relevant point. So I'm glad he brought it out.
Okay, that's good. So once you tell me all those terms you've used for urinary symptoms, what is urgency? What is hesitancy? What is increased frequency? What is nocturia? What is incomplete void? What is incontinence? What is dribbling?
Sir, urgency is when patient has this urge to urinate, and while going to bathroom, he just passed the urine. That time is called urgency. Hesitancy.
What could that signify? Urgency.
Urgency is that the voluntary control over the bladder is not there, and patient is passing. The voluntary control is not there
over the sphincter.
Or the sphincters.
But that would be
incontinence. That's
incontinence, isn't it?
Yeah.
Urgency is trigonal sensitivity, no? Sensitivity of the trigone, no?
Yeah. So basically, Subhanshu, you talk about neurogenic bladder. So tell me the different types of neurogenic bladder.
So there are mainly 5 types of neurogenic bladder. First is uninhibited bladder. Second one is a reflexive bladder. Third is autonomous bladder. Fourth is and fifth is sensory bladder.
So which symptoms will be present in which side? So as Sir asked, urgency, where will be present?
Urgency will be present.
A cortical bladder?
Urgency, no sir, not in cortical bladder.
What will be seen in the cortical bladder?
Sir, in cortical bladder, there will be hesitancy and there will be hesitancy in.
Which conditions do you think you can get urgency?
Sir, in infection of the bladder.
Chronic inflammations of bladder, yeah.
Of the bladder.
Anything relevant to your current case? Any condition relevant to your current case?
Sir, in cervical myelopathy, upper motor neuron type of region, since the voluntary control is not there, the patient tend to have some urgency.
I don't think voluntary control and urgency go together. Urgency is more of a sensory feedback. Voluntary control would mean that the sphincter doesn't hold down and either you dribble or you lose continence.
Yeah.
Okay, no worries. Go ahead.
So over here, it's kind of very broad when we use the word cortical bladder. But coming, because cortical bladder, there's no term such as cortical bladder. So, yes, if there is a cortical, if you say in quotes, if there is a cortical bladder, they do present with urgency. But most important is sometimes there is loss of insight to passing of urine. So many times they wet their clothes and they're not aware that they wet their clothes. So when you point it out to them, they say, yes, I have wet my clothes. So that loss of insight is very, very important for you to understand the. You can continue.
There is no history of band-like tightness or chest or abdomen. There is no neck pain or neck tilt. There is no history of pain on coughing, sneezing while straining at stool. There is no history of bilateral claudication, low back pain or lower limb radiculopathy. There is no history of involuntary abnormal movements. There is no history of fasciculation, thinning in the limbs.
Shubhanshu, what is that band-like tightness? What are you trying to look out for?
Sir, in case of thoracic myelopathy or thoracic compression, the radiculopathy.
Okay. Currently, what is your primary diagnosis in your head while you've reached this status of the exam?
It's mainly due to cervical compression.
So the band-like tightness should come much lower down. You should tell us about neck pain, radiculitis, radiculopathy, upper limb, Valsalva causing pain, all those before. Like you tell us about the more associated neck symptoms before you talk of, collaterals like tandem stenosis or anything else.
Okay.
Yeah. Okay.
There is no history of breathlessness or difficulty in shoulder shrugging. There is no history of facial asymmetry, facial weakness, paresthesia, visual disturbances, hearing difficulty, headache or dizziness. There is no history of dysarthria, loss of vision, visual complaints, diplopia, facial sensory loss, deviation of face, difficulty in hearing, chewing, deglutination or change in voice. There is no history of trauma. There is no history of night pain, fever, cough, anorexia, weight loss. There is no history of morning stiffness, small joint pain. There is no history of chronic cough, chest pain or hemoptysis. There is no history of abdominal distension. There is no history of any other swelling or neurocutaneous marker over the body. There is no history of waxing and waning symptoms. There is no history of recent infection.
So Subhanshu, just go back to your negative history and take out point by point why you have asked those questions. Basically,
sir, since I am suspecting a cervical compression, if the compression is above C5, if it is in C2, C3 level, then breathlessness will be there because of affection of phrenic nerve. And if it is a higher, then shrugging of shoulder will be difficult because the spinal accessory nerve will be affected. While the facial asymmetry, facial weakness rules out the cerebral causes. Dysarthria, loss of vision, visual complaint rules out the cranial nerve involvement. The history of trauma is the etiological, ruling out a night pain, fever, cough, anorexia, tuberculosis, ruling out tuberculosis as a cause. Morning stiffness, small joint pain, ruling out the inflammatory causes. Chronic cough, chest pain, hemoptysis, abdominal distension, or any other swelling rules out any tumors which might have metastasized to spine. Neurocutaneous markers.
So basically, you're suspecting a compressive myelopathy and you're ruling out the causes for compressive myelopathy.
Yes,
in
sir.
short, you can tell that etiological causes for compressive myelopathy. Okay.
Yes, sir.
Yeah.
Tell me in an exam, because I'd ask Harshal or maybe even Agnivesh. So many negative histories are needed.
Sir, if you ask me, I think if you're going too much into details, probably you know the diagnosis. Means this is
Yeah,
how
exactly.
This is how I would look at it.
Yeah.
This is how I would look at it.
True, sir. But as a part of this thing, etiological diagnoses we rule out with these common things. And I think Subhanshu should be smart here and not talk about breathlessness and shrugging of shoulder, and let examiner ask him. That will be an.
If you are suspecting breathlessness with a phrenic nerve palsy and C3-4, that person has to be bedridden. You can't expect a walking patient to have phrenic nerve so involved that he is not able to breathe.
Yeah. So Subhanshu should be smart here, and let examiner ask him what are the high cervical lesions and how you rule out and all. So that is a brownie point for him, I think.
Basically, leave something for the examiner to ask.
Yeah.
Yeah, I feel just go by the highlights of the negative history and don't, I think this is too much, because this tells me that you already know the diagnosis and you've kind of, in your head sorted it out. Sarat?
Yeah, residents have this habit of pointing out each and every point in the negative history. I don't think it's, you should just cover the broad terms. There's no point going into such great details. I know once you do it, then there will be some examiners who will say, why didn't you ask this? Why didn't you point this? Why didn't you point this? But overall, I feel most of the people are agreeing that there is no point going into such great details for negative history.
Yes, carry on, Subhanshu. Yeah.
So one thing is, Subhanshu, once you make your clinical diagnosis, you have to ask points which support your clinical diagnosis and few negative points which would rule out the differentials, common differentials, what you have of your diagnosis.
Okay.
So that is how you should summarize 3-4 points in favor of your diagnosis, means in history and everything, and few points against the differentials.
Okay.
Yeah, go ahead, Subhanshu.
There is no significant personal or family history. There is a past. The patient has a diabetic mellitus, hypertension, ischemic heart disease on blood thinner, and there is a history of PTCA 12 years back. Currently, patient is disabled with inability to perform activity of daily living, community work, household activities, for which he is dependent on others.
So just coming back, what all did you ask in personal history?
Sir, I asked about his diet, about his addictions.
Why diet is important here?
Sir, non-vegetarian diets and vegetarian diets are deficient in vitamin B12, vitamin D3. So vitamin B12 might cause a non-compressive myelopathy kind of picture for that.
Okay. And addiction?
There is smoking is associated with early disc degeneration. It's given in literature. The patient doesn't smoke.
Okay, carry on.
Subhanshu, you said vegetarian diets are deficient in vitamin B12 and vitamin D.
Yeah, vitamin B12 mainly, sir.
Which non-veg food contains vitamin D? Go ahead.
Go ahead.
I would like to summarize my history. It is an insidious onset, asymmetric, gradual, progressive spastic weakness of left upper limb and bilateral lower limb, distal to proximal in an ascending manner with involvement of position sense. There is a decreased sensation below shoulder and neck, no bowel bladder involvement, no cerebral or cranial nerve involvement.
So, Subhanshu, this is your summary of history or examination?
History, sir.
So history, you better don't use technical terms. You use what patient has described you.
Okay.
So don't use cerebral or cranial nerve involvement. You summarize the history as you would want to hear it from the patient, which will help you clinch the diagnosis just by hearing it.
Okay.
So here, all the points should be what he has told you in his own language, as Sir is saying. And you should not use all this spasticity and you must not use cerebral and cranial nerve involvement here, because that's a finding at the end of examination and not the end of the history taking.
Okay.
Yeah. So you would want to again re-summarize the finding history.
The patient has an insidious onset, gradual progressive weakness of left upper limb and bilateral lower limb starting with starting with fingers and foot and going more proximal with difficulty in maintaining balance, with difficulty in assessing whether the clots has been born or not, without any bowel and bladder involvement.
Okay, what is your diagnosis, or what are you thinking at the end of your history?
Sir, my most provisional diagnosis will be progressive compressive cervical myelopathy with motor involvement, likely to be at or above C5 without bowel bladder, most likely due to extradural extramedullary compression.
So why do you say extradural?
Sir, the patient has asymmetric involvement. Then it is a gradual onset, not there is a sacral, there is no bowel bladder involvement, while in intramedullary there will be an early bowel bladder involvement. There is no, that's all.
And any points against extradural?
The sensory, in extradural, sir, the sacral sensations are sacral sparing is not there, while in intradural there is sacral sparing is there.
Intramedullary.
Yeah, you're correct.
Intramedullary.
So you use the word extradural and intradural, and you're talking about all the points in extramedullary versus intramedullary.
Vanshu, what is dissociated sensory loss?
So normally when there is a compressive compressive myelopathy, compression at a spinal cord level, the patient has a loss of sensation, a loss of posterior column sensation, mainly vibration sense, the crude touch on the same side of the lesion, and on the opposite side, on the contralateral side, the loss of the pain and temperature. While in a dissociation of sensation, it won't be there. The patient might be having the same side, both involvement of spinothalamic and posterior column involvement.
No, why is it called as dissociated?
Sir, the dissociation, so because it is involving the two different sides at the same level.
No, it is called as dissociated because in intramedullary lesion, when the lesion expands from the center, it cuts off the crossing fibers of the spinothalamic, which leads to loss of pain and temperature. So these patients have preservation of posterior column sensation and absence of spinothalamic sensations. So that is why it's called as dissociated. You're understanding?
Yes.
So the loss of pain and temperature sensation, but posterior column sensations are fine touch is preserved.
Intact.
This is why it's called as dissociated, not because of anything else. Now I want to ask you a question. What is your level of compression?
It might be at or above C5 because the patient is not able to do overhead activities right now.
So why are you saying above C5?
Sir, because patient right now is having, as I said, there is a difficulty in doing overhead activities, and there is a loss of sensation below the shoulder. That's why it will be above the C5 level, like at or above C5.
Okay. Now coming to the earlier point, I don't use one point against extradural compression is absence of radiculopathies. There are no radiculopathies.
Yes. Thanks.
So the absence of pain, no absence of local pain and absence of radiculopathy is a point against an extradural compression in this case.
Subhranshu, what is the neurological level when you say a neurological level?
Sir, for this patient?
No, what is the definition of a neurological level?
Sir, the level at which the sensory loss is present.
But sensory is a tract, no? So
Yes,
it
sir.
can happen. Let us say you have a involvement of the tract. So the sensory loss could reflect at least 3 or 4 levels down. So normally when we say neurological level, what do we mean? I mean, or what neurological deficit is actually represents the neurological level. It's the anterior horn cells. Because if you have damage to anterior horn cells, that is the level in which you can have the neurological deficit. So if you have cutoff of the sensory pathways, let us say posterior column, so you'll end up having sensory loss at least 3 or 4 levels below. Spinothalamic, same thing. If they don't cross at the same level, they cross, at least 3 or 4 levels above. So again, you could have some cutoff from below. So based on that, you make a diagnosis. Now in neurosurgery, I don't know how it is presented here, but in summary, we encourage the person to speak a scientific language. So the language what is spoken is quite okay. So we would say that asymmetric spastic quadriparesis, but it's also important for us to mention the level and also the plane of compression. So by level, we mean at what level do you think is the compression? And by plane, we mean is it extradural or extradural intramedullary, or I'm sorry, intradural extramedullary? Intradural extramedullary or intramedullary. So that is a plane of compression which we would like to say. And then finally, we state a pathological diagnosis. So fundamentally, we use a 4-tier system to do a summary. First is a summary itself, which is spoken in the scientific language once the history is over, during the history only. B, we talk about the neurological level. 3, we talk about the level of compression. 4, we think about the pathological diagnosis of what could be the probabilities.
Sorry, Sarat sir, one question. All of this is without examining the patient?
Yes. All of this is without both examination as well as in history. We ask them to make this diagnosis.
No, once examination is there, then definitely all of these terms, I think, can be included.
Yeah, but history taking is so important in neurological examination that with history taking, you can actually make 80% of the diagnosis.
Yeah.
So with examination, you are just, kind of confirming whatever you have done in the history. So that is why we use this both for clinical examination as well as for history. This kind of four-tier system of diagnosis.
Sir, I would for the benefit of all the fellows, I would want you to how do you make confirmation of your levels on history? So do you have any protocol where you confirm the level?
So the most important is the sensory level. So we ask where exactly is the sensory level. So if he says at the level of the shoulder, so we say it is C5 or above. That is the thing which is very important. Second is we ask about atrophy and vasculations. We say that till what level. Let us say many patients, they have vasculations at the back of the neck or below, then obviously the level is much more higher. But if they say vasculations is only over the arm or the forearm, then we think it should be maybe at the level of C5 or so. And then of course the local pain or deformity or whatever they have. So based on this, we make an offer the history available. This is what I think, but I need to verify it with examination. So you can always add this disclaimer at the end of your summary.
And one more point I want from you, sir. Is there any specific history which differentiates between intradural versus extradural?
See, if it is in extradural, you would like to have, usually they present with bilateral radiculopathies. So presence of bilateral radiculopathies is more in favor of an extradural compression. Presence of pain, local pain restriction on neck movements again is in favor of an extradural pathologist. Okay. In CV junction, sometimes they could have a bibrachial weakness or a crossed hemiparesis, a crossed paralysis. So there could be hand involvement on one side and leg involvement on the other side. Or they could have a bibrachial weakness. So bibrachial weakness because the hand fibers cross slightly above than the leg fibers. So your dens could be pressing on the area where the hand fibers are crossing, which could lead to bibrachial weakness. So these are the histories which have to be brought out in any case of high compressive myelopathy. And finally, we in the history level, we can say it's above C5 and below C2. You have to add that clause because above C2 becomes brainstem. So we're not talking of brainstem compression, we are talking of spinal cord compression. So you need to always say it's a high cervical cord compressive myelopathy, and my localization as per the history would be anywhere above C5 or at the level of C5, but below C2.
Okay.
And then in examination, we ask what are the pointers which can further localize between C5 and C2. So maybe the fellow can answer. So can you answer me? So let us say, okay, maybe we'll finish the examination and then we can ask.
Yes, sir. Yes, sir. Subhanshu, you actually started with compression, but I would want, for the benefit of this crowd also, what are the pointers in your history which tell you it's a compressive myelopathy and not a non-compressive myelopathy?
So compressive myelopathy has a gradual onset, while non-compressive has an acute onset. Then the compressive myelopathy will have a symmetric involvement, while a non-compressive will have a symmetric involvement. As I said, there will be an ascending type of weakness in a compressive myelopathy, while in a non-compressive, it most likely to be a descending type. And non-compressive myelopathy are mostly associated with a element type of lesions leading to hypotonia and while compressive myelopathy is mostly associated with spasticity, increased tone.
Okay. And any point regarding bladder and ball?
Yes, sir. In a non-compressive myelopathy, the ball bladder involvement will be much early compared to compressive myelopathy.
Okay. Again. Come again.
In a non-compressive myelopathy, the ball bladder will be early compared to compressive myelopathy.
I think it's vice versa. Compressive will have
what did he say?
He told non-compressive will have early ball bladder involvement. I think it's ulta.
No. The intramedullary myelopathy will have a early bladder ball. Is right. That's what he's saying. Sarat sir, isn't it?
Non-compressive has an early bladder ball bladder.
Yeah, non-compressive. Yeah. So intrinsic myelopathy or intramedullary tumor will have an early ball bladder involvement. In a spondylotic or a compressive myelopathy, it will be the last to get affected.
Okay. Subhanshu, any examples of non-compressive myelopathies?
So non-compressive myelopathies like transverse myelitis, it can be multiple sclerosis, then Friedreich's ataxia, then SC, subacute combined degeneration, and
okay.
And this patient have GBS?
So GBS normally affect the anterior horn cell and associated with hypotonia. This patient has a spastic weakness.
Can he have multiple sclerosis?
Sir, I have ruled out by asking him that whether there is any waxing or waning or previous episodes of multiple sclerosis. And as per the history, it was not.
Cervical myelopathy also has waxing and waning episodes. Any other history that can make you rule in, or any other reason why he doesn't have MS? Come on.
Multiple sclerosis are mostly is a demyelinating disease, so it lead to an hypotonia, and this patient doesn't have that.
Can he have a cerebellar tumor?
Sir, cerebellar are generally cerebellar. If there is a cerebellar affection, there won't be any sensory loss, but the patient has a sensory loss too.
Can he have a hysteric episode?
Sorry, it's been a gradual onset since long. I don't think hysteric onset.
Subhanshu, you know of any other pathology where there may be a waxing and waning like this?
So cervical myelopathy and multiple sclerosis, except for these two.
Yeah.
So in rheumatoid arthritis, but is not associated with.
Sometimes it can be seen in AVMs. Means like if you have a this
Malformation.
spinal, arteriovenous malformation, they may have some kind of waxing and waning sometimes.
Oh, okay.
Sir, anything to add in the history?
No, I'm quite okay with this.
Yeah. Carry on, Subhanshu.
I have examined the patient in supine, prone, sitting and standing from front, back and side as and when required in an open and well-lit environment. Patient is conscious, cooperative, well-oriented to time, place and person.
And this is yet
moderately built and moderately nourished. There is no pallor, icterus, cyanosis, clubbing, edema, feet, generalized lymphadenopathy, enlarged neck veins or neck swelling. Vitals are stable. No neurocutaneous marker or no tropic changes is lower or upper limb. On systemic examination, CVS, RS and per abdomen examination was normal. I examined the gait, which was a bipedal, unassisted, broad-based, staggering, unsteady gait. Patient find it difficult to do a tandem walking, and the Romberg sign was present. On inspecting from the back, head is well centralized over pelvis, normal posterior hairline, both shoulder and scapula at the same level, no truncal asymmetry or list, no step of deformity, both PSIs at the same level, both popliteal crease at the same level, no coronal imbalance. From side, head well centralized, no exaggerated cervical or thoracic kyphosis or lumbar lordosis or loss of lumbar lordosis. Both hip and knee are in a straight posture, no sagittal imbalance. From front, head well centralized or shoulder, no facial asymmetry, chin position was sternal notch, no chest deformity, both ASIS, patella, middle malleolus at the same level. On palpation, all my inspectory findings are confirmed. There is no local rise in temperature or no superficial deep tenderness. There is no palpable paraspinal muscle spasm, no palpable step or kyphotic deformity.
Can you comment about kyphotic deformity in cervical spine by palpation?
Repeat, sir, what your question was?
So, are you able to normally palpate all the spinous processes in cervical spine?
Not all the, sir, but C2, C6 and C7 we can palpate.
So can you objectively say it's there's no kyphotic deformity in your palpation?
Yes, I can't be sure, but by what I examined, it was not there.
Okay, and how do you check the tenderness?
Sir, there are two types of tenderness to check: superficial and deep. Superficial are checked with touching your fingers. If there is any infection or inflammation of the skin, then the patient will complain of the pain. In a deep tenderness, you check with a thirsting, which gives you, if there is any anterior pathology, it tells you about that. Rotatory tenderness, you keep your thumb on both the side of the spinous process and you try to rotate it. It also gives you about the anterior pathology. And deep tenderness with thumb pressing directly over the spinous process, it indirectly gives you the pathology being the posterior.
So is the method correct that you hold just one spinous process and rotate, or there is something else? Other hand, what is it doing?
No, sir. Thumb on both the side of spinous process, and you tend to rotate it.
Or do you stabilize the spinous process above and rotate? Is that the way?
So on the side.
And try pressing on your own spinous process. You will also have the same pain. So what is the crux? When do you say it's tenderness positive?
If the patient wins with the pain.
No, patient says he has the same pain as he has, which he's complaining of.
Yes.
And what is the significance of tenderness here in cervical myelopathy?
Sir, if there is local tenderness, there is a deep tenderness, then it might be due to a localized infection or like tuberculosis and abscess formation.
Okay, carry on.
So the movement of the cervical spine was within the normal limit. I checked for flexion, extension, lateral flexion, and rotation. The measurement was done with the occipital to out test, CS to C7 VL plumb line, mastoid to GT plumb line, and muscle vesting all were normal. On neurological examination, higher function, patient is conscious, cooperative, oriented to time, place, person. Cranial nerve examination was normal. Motor examination, tone was increased. Nutrition well nourished. Involuntary movements were absent. These were the power. The neck muscles were 5/5. In the upper limb, the left side it was 4/5 with hand grip weakness. In the lower limb, on the right side it was 4/5. Left side it was 3/5. All the limbs. I checked for the reflexes also. The superficial reflex, gag reflex was present. The abdominal reflex was absent. Cremastic was absent. Babinski was positive. Hoffman was positive. Georgia was absent. Scapulohumeral reflex was absent. Biceps was exaggerated. Supinator was exaggerated. Triceps was exaggerated. Brisk knee jerk was also brisk, and there was an ankle clonus present. I checked for the incoordination, the finger.
So you came through very fast in motor examination. So coming back to tone, what else you're supposed to say in tone? You said just it's hypotonia. What are the different types of hypotonia?
Sir, the hypotonia might be due to spasticity or rigidity.
What's the difference between spasticity and rigidity?
The spasticity is mainly due to upper motor neuron region involvement of corticospinal tract, while the rigidity is due to the involvement of cerebrospinal tract.
What are types of rigidity?
Extrapyramidal.
Types of rigidity.
Sir, rigidity types are the lead pipe and cogwheel type of rigidity.
Do they signify anything?
So this suggests that there is involvement of cerebrospinal tract.
Which one suggests
involvement? Extrapyramidal involvement.
Which one suggests what?
Any significance of cogwheel versus lead pipe?
Okay. Cogwheel.
How do you check the fifth cranial nerve?
So the fifth cranial nerve is checked by sensory and motor involvement. Sensory of the face, is a trigeminal nerve. So the upper part, the middle part, and the lower part. And the motor involvement. The trigeminal nerve is the muscles for mastication. And
so which muscle? Because there are many muscles for mastication.
So masseter is there, lateral pterygoid, medial pterygoid is there.
How do you test the pterygoid?
I just check for the masseters. Clinching.
What is the action of the pterygoid?
So the medial pterygoid causes the forward
correct, you're correct.
The forward movement of the mastoid, while the lateral pterygoid,
the mandible.
Mandible, and the lateral pterygoid causes the deviation of mandible to the opposite side.
Okay. Okay.
Yeah.
Sarat, you're muted, Sarat.
Sir, you're muted, sir. Sarat.
So sorry. So which component of the fifth cranial nerve is important in spinal compression?
So it says spinal nuclei.
So which how do you test for that?
So, with the jaw jerk.
Jaw jerk is very non-specific. So what happens if you have a compression at the level of C2? Could you have any sensory loss on the face?
Yes, sir.
Which part of the face?
So the lower half.
Which half? Can you put your finger and show it?
So below the nasal pulp.
No, not at all, not at all. So see, there's a difference. The divisions what you're showing here are the divisions which happen beyond the Meckel scale. Okay, the V1, V2, V3 divisions. But within the spinal cord, they're not divided in this way. So the distribution within the spinal cord is in form of a Balkalva's helmet. So Balkalva's helmet is a French helmet. I don't know if you have seen some cartoons, they have this pointy face. So if you open up, it opens up it's got concentric rings. And if you open up, the face opens up. And when you close it, it kind of snaps shut. Okay. So in this case, you have sensory loss happening around the jaw line, just below the ear. Because it's an onion peel kind of a sensory loss which happens.
Okay.
And this happens because the spinal nucleus of the fifth nerve, it loops down till the level of the C2. So sometimes when you have compression at the level of C2 also, you could have sensory loss around the face. So this is one of the pointers which differentiates you. See, normally it's not possible to localize above the level of C5. But there are certain pointers which can provide you some degree of localization between C2 and C5. Not always, but sometimes. So this is one of them. Sensory loss along the jawline, which is because of involvement of the spinal nucleus of the trigeminal nerve, is a very, very important. Can you name any other signs which can indicate a compression between C5 and C2?
So the spinal accessory part of the spinal accessory nerve might be affected.
Spinal accessory, okay.
You also mentioned the same in negative history.
Anything else? You could have affection of the phrenic nerve.
Yes.
C3-4 root.
Yes. C4.
Okay. So these are the pointers between. Then you could also have involvement of the rhomboids, which is a C5. So if you have weakness of the rhomboids, again, that localizes between C5 and C2. So these are the final localizing points. So you could have sensory loss along the spinal nucleus of the fifth nerve. You could have involvement of the rhomboids. You could have involvement of the phrenic part of the phrenic nerve. You could also have involvement of the spinal accessory nerve. So if you have all the following components, you may think that it kind of localizes you nicely between C2 and C5.
Sir, even Sarat sir, even Horner syndrome and vertical nystagmus can be indicators.
Horner syndrome, yes. Horner syndrome more commonly happens. See, there are three parts of the Horner syndrome. So 1, 2, and 3. So it exists and goes above. So level 1 involvement can happen when it is inside. Usually in the intramedullary lesions, it's involved.
Okay.
The second order of the neurons goes above the lungs, below the subclavian. So if there's involvement there, over there, it can happen. The third order is much more distal. It goes along the plexus, around the internal carotid artery. I think if I can recall my anatomy, that is what it is.
Okay.
So Horner's usually indicates presence of an intramedullary lesion.
Carry on, Subhanshu. Yeah, you're talking about the reflexes.
So
Tell me what is normal Babinski reflex?
So normal Babinski so there is no normal Babinski. The Babinski can be either positive, there is normal plantar or upward plantar.
Good.
Second, the Babinski is used to check whether there is a upper motor neuron type of lesion, in which after exposing the patient till the thigh, you hold the with left hand you hold at an ankle, and you stroke on the lateral border coming towards the ball of the ball of the foot, and check for the finger flexions or fanning. So if it is the great toe or the finger go into flexion, it is called as a plantar downgoing, and if it is associated with greater toe extension with finger extension, fanning on the finger extension, it is supposed to be Babinski positive or plantar upward extensor.
Harshal, you are muted.
What are the different variations of plantar reflex? Any names?
There is an open hammer reflexes where you strike along the shin of the tibia. Then Gordon
Strike along.
You squeeze the shin of the tibia.
You press along the shin of the tibia from proximal to distal.
Yeah, proximal to distal. Yes. Then Gordon reflex, which is a pressing of the calf muscle. Then
is it calf muscle or tendocalcaneus?
Gordon is calf.
Sarat sir?
Yeah, you have number of variations. I think the names are not important. One is you run along the shin of the tibia. So that is called as the Schaefer's. Gordon's is, I think, you squeeze along the calf. Then you can also squeeze along the Achilles tendon. You can take a pin and keep on pressing it. You can put number of pin pricks over the little toe. Now, the fundamental mechanism, what you have to understand is, unlike a deep tendon reflex, where it is a single point action, I mean, you tap it and then you get a reaction. It's all a non-reaction. A Babinski's reflex is a much more evolved reflex. It depends on two factors. It depends on the intensity of the stimulus and the duration of the stimulus. So let us say the intensity and durations are not matching up on the palm, on the plantar surface. So you have to increase the intensity, or you have to compensate the intensity and duration by providing stimulation somewhere else. So whenever you do Gordon, Schaefer's, Gonda's, or whatever this reflexes, it has to be combined along with the plantar reflex. So eliciting plantar reflex is an art. It requires a lot of experience for you to elicit a plantar reflex. So I just want to ask the fellow, can you tell me what is the pathway for the plantar reflex?
So it is elicited by the S1 nerve root. The afferent fibers, the afferent fiber is carried through long saphenous nerve, and the efferent are efferent are carried by anterior tibial nerve.
But where is the central processing? Where does the central processing happen?
At the level of S1 spinal.
So is it a local spinal reflex?
Yes, sir.
So how is it different from a deep tendon reflex? So this is very important. I mean, you should not forget it. A Babinski's reflex, plantar reflex is never a local reflex. It goes right up to the cortex. It is a cortically mediated reflex. You can never forget this. And that is why its responses are so complex. It's got so many variations, it's got so many variables in order to elicit a plantar reflex. Are you understanding it?
Yes,
It's
sir.
not a local reflex.
Sorry.
That's a blunder. That's a mistake. Okay, it goes right up to the cortex. A deep tendon reflex is a primitive reflex. It's a local reflex.
Yes.
A plantar reflex is a highly evolved reflex. It goes right up to the cortex. It's a multi-synaptic reflex. A deep tendon reflex is a single synapse. That's it. There will be at least 100 synapses in a plantar reflex. Can I ask you one more question about plantar reflex?
Yes, sir, please, sir.
Yes, yes.
So let us say his legs are amputated. How will you demonstrate plantar reflex?
Sir, by striking the edge of the amputated leg, if we see a contraction of the TFL, tensor fascial lata, then
Okay. So tensor fascia latae and the adductor muscles. More important is adductor muscles. Okay.
Sir, would you call Hoffman's as a superficial reflex?
Hoffman's one which is elicited in the upper limb?
Yeah.
No, it's a cortical reflex. Yeah, it's a superficial reflex.
Okay.
They're all superficial reflexes.
Sir, correct me if I'm wrong. Hoffman is just to stimulate the flexor tendons by leaving and stroking.
By Hoffman, you mean, what do you exactly mean?
Yes, sir, the Hoffman, the DIP one.
Flicking of fingers and you see a reflex
Okay.
contraction. That's akin to a deep tendon jerk only.
Maybe it's a deep tendon.
Because you are just stretching the tendon and leaving sort of.
Yeah, I'm sorry, I thought it's the Wartenbergs. So when you said Hoffman, I thought it's Wartenbergs.
Hoffman and Tromner's are more akin to
Deep tendon ones.
deep tendon jerks only. It's
So
just a
From the sign.
You're right.
From the sign.
So the Wartenberg's reflex, the one which is done like this. Okay. So this is a normal response of the thumb. And abnormal is it becomes like this whenever there's a weakness. That is the synonymous reflex of plantar reflex in the upper limb. Okay, that's the superficial reflex.
Sorry, Abhay sir, you were saying something.
Yeah, Tromner sign. Tromner sign for Himanshu. So Himanshu, what's Tromner sign?
Tromner sign, sir. No idea, sir.
Okay. So
It's like, sir, you want to tell or?
no, you tell.
So it's like Hoffman only what we do. So in Hoffman, you flick the finger. So you flick the finger like this and you get a contraction. In Tromner's, instead of flicking, you give a tap from below like this. So you see a reflex contraction of the fingers.
I think all these guys are very lucky.
They got names added to their tests. Sir.
Yeah, they managed to get a name tag to them for every small thing they described.
So Hoffman, they used to ask us who actually described Hoffman. Because the answer is that his assistant described it and he got credited for it.
Oh.
There's some name of the assistant also. So if you're scoring well, they may want to know that.
One more, since sir has brought this point. So Vanshu, one more this thing, sort of out of context question for you. You know what is the difference between the Babinski test and the what Plantar we do now? Or how did Babinski come across this test? How was he able to find it? So Babinski in his ward rounds had a habit of stroking the feet of the patient, of every patient, whoever he passed at the end of his examination or consult. And that's when he noticed that certain people respond to this stroking in a different way. So the terminal sort of inward movement where you move from the ball of fifth toe to the ball of first toe, this was not described by Babinski in his original test. It came later as it became more refined and more.
So, Subhanshu, when you are told about the Babinski, I wanted you to tell me all the specifics, that what happens to every joint but that you must read afterwards. And good to know this story from Agnivesh sir, that how habit became the sign in neurology.
But I'm curious, why would he go on stroking everybody?
So there's a very beautiful sort of small booklet on the life of Babinski and all, and there's where it is described.
Okay.
So I just came across to it randomly and I read that book. So that is how it was described. It's what it meant.
Subhanshu, you told supinator is hyperreflexic, right?
Yes, sir.
Supinator jerk. You in your exam in your history the level was C5 C6. Do you expect something else in supinator jerk?
Sir, if it is at a C5 C6 level, then the supinator will be an inverted radial reflex, which I'm not finding it. It was brisk in our case. So the lesion might be above. So if it is at a C5 C6 level, then it is it causes inverted radial reflex, in which on tapping.
What is that exactly? Yeah.
It is on tapping of the brachioradialis tendon. Normally in a supinator reflex, we give a flexion of the elbow, and if it is exaggerated, the finger flexion also. But if it is an inverted reflex, there will be absent contraction of brachioradialis. There will be no elbow flexion, but the finger flexion will be there. So that is called as inverted radial. It's suggestive of element at C5 and element C6. Sorry, element at C6 and irritability of C7 C8.
No, but you missed a very important finding in that. Only finger flexion or something else happens?
Finger flexion and thumb adduction.
Anything to add, sir? Perfect. Carry on, Subhanshu.
So there were no cerebral signs are absent.
Oh, one more question for you. Define clonus.
So clonus is continuous repetitive movement caused due to sudden stimuli.
Sudden passive stretch.
Passive stretch. Sudden passive stretch.
Yeah.
So this is a video of Hoffman test.
Okay.
Is it always positive for upper motor lesion? 100%?
No, sir, it's not that specific. Not always specific.
Yeah, almost like 5% people have it positive even without a pathology. Okay.
Yeah.
So just one more question, Subhanshu. What are the conditions where you may have hyperreflexia? Means which is not pathological hyperreflexia.
So upper motor neuron type of lesion, if it is there, spinal cord compression. If it is a cerebral involvement, cortical like hemiplegia, that time. That's all.
So thyrotoxicosis, it can present with
Yes.
hyperreflexia. Anxiety, any anxious patient will have his reflexes exaggerated. So these are the two I know. I'm not sure, means if there are any else. Then.
Okay. On sensory examination, fine touch decreased below C5 level. Pain and temperature was normal. Joint position at grade 2 ankle and knee absent. Vibration sensation absent over medial malleolar and shin of tibia. Perianal sensation was present. On doing a special test, Lermit sign was negative. Spur lung was negative. Finger escape sign was positive, and grip and release test was positive. This is a video of a grip and release test. Finger escapes.
Can you describe how it is done?
Sir, I will ask the patient to extend the upper limb and keep it hold and hold it at eye level, and hold it. After some time, the ulnar fingers will try to deviate. That's why called as finger escape sign. It's a sign of a myelopathic hand.
So can you enumerate all the different myelopathic hand signs?
Sir, it includes finger escape sign, then grip and release test, then Hoffman sign, and that's also. They are
There's no,
mainly
there's no sir except one more Wartenberg sign.
Yes, sir.
Then one more important you are missing out. Flexopronator drift. Yeah. Carry on. You write later.
On other systemic examination, SI joint was normal. There is no lymphadenopathy and distal pulse was present. So the positive finding from the examination was broad-based case, sensory level at C5. There was grade 2 tone, which was spastic, predominant posterior column involvement. Power is 4/5 at left upper limb, 3/5 at left lower limb, 4/5 at right upper limb. Romber test was positive. Abdominal and cremastic reflex was absent, while that deep tendon reflex was brisk and Babinski was positive.
Okay. So what grading system you use for spasticity? What is the name?
Sir, modified Ashok.
Okay. So diagnosis.
So my diagnosis is a progressive compressive cervical myelopathy with spastic left upper limb and bilateral lower limb weakness with sensory level at C5, with most common cause being extramedullary compression, with etiology being degenerative cervical myelopathy or infection or intradural extramedullary compression.
Sarat sir, you want to comment?
No, it's okay. It's quite okay.
Yeah, I think it's good. Only the most common name, most likely is what you have to say. Because common is a statistic and likely is what you're thinking.
Okay, sir.
Sir, should we use OPLL and OLF as diagnosis in clinical, because those are, I think, radiological diagnosis?
Yeah. So but then when he says degenerative cervical myelopathy, that again becomes a radiological diagnosis. So compressive cervical myelopathy, you could say likely degenerative, or could be something else like OPLL or OLF, like in a very casual way. But if you say degenerative cervical myelopathy, you're as much talking of a diagnosis as you would of OPLL. So you'll have to tread softly.
Sir, one more question I have for Sarat sir. Sir, when you have spasticity, should we comment about MRC grading of muscles?
Yes, so that's a very important question. So everything depends upon the degree of spasticity. So if you know, there is something called as, the traditional teaching tells us that if you have cerebellar signs, you should not comment on power, or vice versa. If you have weakness of the power, you should not comment upon cerebellar signs. But there is also a condition called as ataxic hemiparesis. So in ataxic hemiparesis, the power could be around 4+/5. And then the patient has very severe ataxia. There's very severe finger-nose incoordination. And the ataxia is disproportional to the degree of weakness. So same thing stands for spasticity. The spasticity should not be disproportionate to the amount of weakness. So if there's a severe spasticity, you can always say the spasticity is too severe for me to actually comment upon the power. But otherwise, mild to moderate spasticity, you can always test forward. That's not a problem.
Okay. Agnivesh sir, you want to ask something?
No, I think we are good. He has done a good job.
Yeah.
Sir,
Subhanshu,
I would like to ask whether we need to include MJOA score or anything like numeric rating in the diagnosis.
No, I think that is not required in the history and examination.
In diagnosis, if we don't have to.
Yeah, means don't complicate situation for yourself. That's all what I would say.
yeah. So a proper clinical diagnosis with what is the localization, what is the pathology, what do you feel etiology is, or most likely diagnosis of etiology. I think that should suffice.
MGOA score, nobody's going to remember. But neurics, you let the examiner ask you that, so what neuric grade you think it is. So that is how I would think of it. But I'm not sure, maybe Abhay sir or Sarat sir can give their opinion.
As an examiner, you would want MGO score to be told by a student?
No. I said that I don't think that scoring and all should be mentioned. As I said, leave something for the examiner to ask. Certain things for the examiner.
Yeah. Sarat sir, I had one question for you. When we talk about the localization, we talk about the vertical extent of the lesion or vertical extent of pathology. So to say broadly, the motor level would be a upper vertical extent and the sensory level be the lower vertical extent. To say that, or no?
No. So the exact vertical extent can only be determined by the anterior horns.
Okay.
Then the sensory level would be the highest level.
Okay.
So you can always take the sensory level as the highest possible level of involvement. The lower extent can only be determined by the anterior horn cell involvement.
Okay.
So if the patient has vascular, that's the only proper thing. Otherwise, the sensory level is a very gross estimate. You have to kind of match, you have to subtract certain levels from the vertebral level in order to determine the sensory level.
Right. Thank you, sir.
Subhanshu, one question for him. If the patient has a C4-5 disc, then what level you expect?
Sir, if he has a C4,
we are talking about cord levels, not root levels. So
C4, C5, then there will be an affection of anterior horn cell at that level. So C4 nerve root will be affected. So a lower motor neuron type at C4 nerve root, and below that there is upper motor neuron type.
So I think because at the level of compression, you can get a mixed picture. So probably if it's a let's say C5-6 compression, so you even with C6 may also have some lower motor signs or that. And then below that level, you will get a clear myelopathic picture.
Yes, sir.
Right.
Okay, Subhanshu, what would you like to do?
Sir, I would like to investigate the patient further by doing X-rays, by radiological investigation.
Okay.
Sir, this is the X-ray of the patient, anterior, posterior, and the lateral view, which is showing, which is normal in alignment. Lordosis is maintained. There is some degenerative changes are seen with reduced disc height at 3-4 disc space, also disc ossified at 4-5-5-6 level, 6-7-5-6 level. That's all in the X-ray. We did a flexion extension view to check for the instability also. There was no as such angular or any translatory instability.
This is the significance of osteophytes. Can you go back to the X-ray and tell me about these osteophytes? What's the difference between osteophytes, claw spurs, ossification of annular ligament?
Sir, claw spur is a sign of an instability trap where the vertebral body is trying to make the vertebra stable.
Do you see any here? Do you see any claw spur here?
At sir, this level there is one, and this here is claw spur.
Then what is an osteophyte?
Sir, osteophyte occurs due to the ossification of the this annular fibers, and
So how will you differentiate on the X-ray which is a claw spur and which is an osteophyte?
Sir, the claw spur will start from the anterior border of the vertebra, while the osteophyte will start from the inferior angle of the vertebra.
Right. It'll start from the edge. What about the direction?
Sir, the direction along the fibers of the ALL and the annular fibers.
Yeah, the
And
claw
for-
spur will be very transverse. It will be
Transverse.
absolutely transverse, and the osteophyte will be more directed down. What about annular calcification? Do you see that in this X-ray anywhere?
There is some annular spur-like calcification at this level.
Do you look at it at the back or at the front?
So sorry, sir.
Is there any scoliosis on this X-ray?
So there is no, sir. The definition is less than 10 degree. If it is not if it is less than 10 degree, we don't call it as.
Have you measured it?
It looks like less than 10 degrees.
Okay. What about the occiput? When you look at the X-ray, is there something you see in the occiput? Is it normal?
So it looks normal.
What is that bump?
Posterior, go more posterior.
Yeah, what's that?
The occipital protuberance.
Is it normal?
It's normal.
No, it's not normal. What is it? It's a traction spur. It's a traction spur there. So basically, he has an ossifying tendency. Even if you see the posterior element of the C2, you'll find some ossification. Even at C7, you'll find posteriorly the supraspinous ligament ossifying. So he has this ossifying tendency throughout.
Yes.
And that's what's being seen on the X-ray. All right. Okay.
Go ahead, Subhanshu.
Subhanshu, you said less than 10 degrees is not called scoliosis. So what is it called? You refer it to as asymmetry, right? Spinal asymmetry.
Okay.
Okay. Describe your MRI.
Sir, these are the T2 images of the MRI of the cervical spine with sagittal and axial section. In sagittal section, we are able to make out there is the alignment is maintained, the lordosis is maintained. There are
You don't talk about alignment in MRI. MRI is taken lying down.
Okay. The anteriorly at the level of C3, C4, there is compression and there is a multi-level compression between C3, C4, C4, C5 and C5, C6. Also, there is some posterior compression at C3, C4 and C5, C6. Most likely due to a disc osteophyte complex at C3, C4, and at posterior level due to ossification of ligamentum flavum. The main compression is
with this MRI. Can it be a large disc prolapse and not a disc osteophyte complex? How can you make it osteophyte complex on an MRI?
So the disc osteophyte complex will be a cortical bone, so it will give a low intensity signal at T1 images. But here at the T1 images, you are able to see the shadow. The signal intensity is similar to the disc level. So it's most likely to be disc osteophyte and not calcified.
Okay. And also the age.
Yes, the age of the patient.
Okay.
Also,
Anything else you want to describe?
Also at the spinal cord level, there is T2 at T2 there is a hyperintensity signal changes at C3 C4 level, which is hypo intense at C3 C4 in T1 images, which shows a poor prognosis for a long term.
What do you mean by that?
So that means the scarring is long term.
So is it a cord edema or a myelomalacia change?
No, myelomalacia.
Or a syrinx. Is it a syrinx? So tell us, why do you think it's a myelomalacia cord, the cord edema, or a syrinx?
Sir, in edema, the cord will look in myelomalacia the cord will thin out, while compared to the edema it will be more thicker. Also in the T1 and T2 images in myelomalacia, it will in T1 T2 images it will show hyperintensity, and in T1 images it will show
Hypointense. Yeah.
Intensity compared to cord edema, which shows hyperintensity in both the same.
Correct. Okay. Anything else you want to point out? Do you find any thickening of PLL here?
There is some thickening of PLL at C3, C4, and C5 level, which can be compared with the lower level. It seems to be thickened, but I don't. For to say whether it is calcified, we need a CT scan.
Okay. Agnivesh sir, you want to add anything?
No, nothing. There are certain those MRI sequences, I'm forgetting the name, where you can actually see the calcification. So there are some sequences which can tell you even on MRI that these are calcified. But having said that, you should get a CT. There is no doubt that you should not get a CT scan done in these cases.
Okay. Anything else, Subhanshu?
So there is some ossification of ligamentum flavum at this level, 4-5. And there is some, not ossified, but ligamentum flavum buckling at this level and this level and this level. The posterior.
Not this. What is the level? You should tell levels, not this.
C4, C4, C5, and C5, C6.
Okay.
So there is a multiple level cord compression with normal lordosis in this patient.
What would you like to do?
Sir, I will discuss this with the patient about the findings, and I will advise him the surgical management, which will involve the
anything before surgery. Anything is missing out yet?
CT scan.
Okay. If you have done CT scan, okay, then it shows OPLL C3 to C6 with a disc ossified complex F3, 4. Anything else?
EMG.
What is tandem stenosis?
Yes, sir. I would like to get a whole spine screening of MRI to rule out any stenosis at the lumbar level or a dorsal level.
Did you rule that out clinically?
Yes, sir.
So would you still want an MRI scan?
Yes, sir, because in 30% cases, if they have cervical or lumbar stenosis, they tend to have the stenosis at other level.
But if clinically he doesn't have any signs of tandem, would the MRI matter to your plan of treatment?
For the plan of treatment, no, sir, but for just documentation purpose.
And expectation settings. No? Documentation is one, but you still need to tell the patient what if he has a listhesis, a grade 1 listhesis, which may come up for something in the future.
Yes.
So you want that scan anyway, regardless. What is why would you want an EMG NCV here, like a neurophysiological testing here?
No, sir. No, not.
Why not?
So EMG NCV is generally done if you are suspecting a case with no signs or symptoms in an early myelopathy, where you want to see whether SSEP are functioning or not. And it also used to rule out medical causes like peripheral neuropathy, myopathy. But in this case, with the history and examination, the diagnosis is...
He's a diabetic, isn't he?
Yes, sir.
So what if he has collateral diabetic neuropathy? After your surgery, if he complains of tingling in the hands, which is persistent, how will you deal with it? Would you do an EMG then?
Yes, sir. That time.
Sir, irrespective of that, Sharat sir, would you be doing EMG and NCV for all your cases of CSM?
No, not at all. Not unless you suspect some kind of a peripheral neuropathy.
Okay.
In fact, that should be completely contraindicated.
So basically gauge how the examiner is going. Because if I'm making a very strong case, then you can gauge my sense and not get into an argument.
Yes.
Okay.
Would you? Is there any role of conservative treatment here?
No, sir. The natural history of cervical myelopathy is that 40% of the patient deteriorate.
Which study are you quoting?
I read it from book. The study.
So it says 40% worsen.
Yes, sir.
So the majority don't worsen.
Yes, sir. But yes, sir.
So you would still say there's no role of conservative treatment?
I won't say that, sir, there is no role of conservative treatment. We can discuss this with patient also, but depending upon that, we can decide whether want to do a conservative management or a surgical management.
So obviously the patient says you decide. What is your strong indication in favor of surgery? Because you've offered him, you told us you offered him surgery.
Yes, sir.
So why?
Sir, there is a progressive worsening over the last 6 months. There is myelomalacic changes seen in the MRI also, and patient wants to have a good life related to activity or daily life and don't want to get dependent on others for that. I will suggest a surgery for him.
Any other reason? If he says, okay, I would like to do this surgery after 2 years, maybe I want to wait for 2 years. What is the pros and cons of waiting?
Sir, if he's the cons are, sir, the patient might deteriorate. Yeah, the cervical myelopathy goes on a step ladder type of pattern, worsens on a step ladder type of pattern. So we need to tell the patient regarding worsening, how to examine him worsening of the symptoms and everything. While the pros are during that time we can increase the management in the form of physiotherapies and all to strengthen the muscle so that it can work post-operative also.
Does the surgery get any more risky if you wait, especially in view of the myelomalacia that you've described?
Yes, sir, because it is at upper cord level. It might affect the phrenic nerve, which might cause a respiratory disturbances also.
Okay.
No, C4.
Yeah.
So basically, you have to whatever treatment you tell, you have to prove your point. So, sir, there is a significant progressive worsening for past 6 months to 1 year. The daily active or daily living are significantly affected, and patient is dependent on his all activities. On checking, he has all myelomalacia, myelopathic hand signs positive. He's not able to perform his hand functions also properly. And on imaging, he has significant myelomalacia changes with cord compression at 3-4 significantly. So I would like to offer him a surgery, and I like to give him pros and cons of surgery, and then you can tell. And again, the chance of, like, you know, all the details, you can prove your point by telling there's a chance of some central cord syndrome by some amount of whiplash in a significantly spondylotic spine. So you can prove your point, and you can always say there's a chance of conservative management also if he is willing to wait that way. I think that would be okay, sir, for your answer.
I think so. You hold your position and then back it.
So Subhanshu, what do you counsel the patient when you tell him surgery? How do you counsel this patient? What do you tell him? So what are the expected things you tell to the patient? Expected things means patient says कि मैं surgery करके एकदम अच्छा हो जाऊंगा ना. So how do you counsel?
Sir, I will suggest him about the decompression surgery and regarding the pros and cons. So after the surgery, the recent literature are saying that there is a grade 1 improvement in the motor, but there is no improvement seen in the sensory front. So that I can explain to the patient. Other than that, there will be the complications. I will explain him about the neurological injury, the vascular injury, the infections and everything.
So you want
Which
to
is this
scare
recent literature that you're quoting?
So I read one, sir. I don't remember.
I don't get into again
No.
controversial. You can say that this is what my reading suggests, but the minute you say recent literature, you will be pinned down on which is the literature, what is the validity of the study, everything else.
Okay.
As long as possible, don't give numbers unless until examiners ask it. So you can tell about the progressive nature, the irreversibility of the changes, and all those things, but never quote unnecessarily numbers and literature unless until examiners specifically ask for the numbers.
Okay.
Subhanshu, is there a possibility that you do a surgery and this patient continues to deteriorate?
For this patient, sir, whether there will be a good cord fallback and everything, I don't think so.
So basically, whenever you counsel these patients, you always tell them that we are doing this surgery to prevent the progression of neurology. That is the aim of the surgery. So whatever recovery you get is more like a bonus, what you will get. And there is a small possibility that despite my surgery, your cord may continue to deteriorate because whatever gliosis or whatever myelomalacia there has set in, it may take some time to stabilize after you relieve the compression of the nerve. So all these things, they need to be put forward to the patient. So your first point in favor of surgery becomes that when you say that we are doing this surgery to prevent the progression. So if you do it at a stage when you are already bedridden, Uric 5 or something, then you don't expect them to be able to walk again and do that. So you need to do it in time so that you can preserve the neurology.
Yes, sir.
Yes.
Looking at this X-ray and MRI, and what was the surgery? I think I heard you briefly that you're talking about decompression surgery. So what are the complications you think of?
Sir, I would like to go posterior laminectomy, and the complication associated with that are the neurological injury. The first, then
What is the chance of neurological injury? Give number. So you want to give that as a first complication?
No, sir. There is chances of dural tear. Then there are chances of C5 nerve palsy because of C5 nerve palsy. Then immediate neurological deterioration because of the hematoma formation.
Okay.
Then infections. Then
okay. You talked about C5 nerve palsy. That was the thing which examiner wants to hear when they're asking this question specifically. the chances of this, why they're higher in, why it may be higher here?
So the lordosis is at C4, C5 level. Because of the cord fallback, there is stretching of the nerve happen, mostly the C5, that causes the C5 nerve palsy.
Okay, would you like to stabilize?
So he is 71 years of age. I would avoid stabilizing him. We'll do a posterior laminectomy only.
So what is the indication to stabilize here? What would have been your indication to stabilize?
Sir, if we so since the level is C3, C4, we might need to go to C2, undercut C2. That might causes a post-operative kyphosis. To prevent that, we can do a stabilization. Or if there is any instability. For this patient, I don't think so. There is no instability in this.
Instability based on?
Flexion extension axis.
How about clinical instability? How do you assess clinical instability in the cervical spine?
Sir, I will ask the patient to bend forward, and if there is any worsening of the symptom, or then it will suggest you of that there is some clinical instability.
What's head holding sign? What do you suspect when the patient tries to hold his head when he gets out of bed?
So the flexion is happening at the spine. So to prevent that, while getting up, he tried to hold the head. That's
a sign of clinical instability. That's what sir is asking.
And it's classic of OC1, C2 instability, where they hold their head when they try to get out of bed. I would like to do an anterior surgery here. You have any problem with that?
that anterior is possible, but due to the involvement of there multiple level involvement from C3 to C5, I would prefer a posterior surgery because it is multi-level.
Would you like to see some other sections before deciding the anterior posterior? Because the sagittal, it can be sometimes fallacious. Yeah, so the axial sections are much better. See, they're giving you a much better.
Yes, sir.
So you'd like to comment on this now?
Sir, there is major compression occurring at C3, C4 in the axial and in the C3, C4 sir, in the axial cut. Also, there is some compression at C4, C5. Intending the anterior dural space, and C5, C6 also there is some compression.
So I think rather than using some you should say mild to moderate, and severe compression at C3, C4. I think that would be better.
Oh, okay, sir.
Okay. Any indices you use to decide anterior versus posterior? I think that was the crux of the question.
Sir, it depends upon three major factors: the patient, how the patient is, whether depending upon his age, whether he is having the comorbidities, depending upon the type of involvement, whether it is more anterior, whether it is more posterior, whether the lordosis alignment or lordosis is maintained, so that after surgery the patient can have a cord fallback, and depend upon the level also. If it is more than 3 level, then it is advisable to do posterior surgery, because it is advisable to do a posterior surgery because it anterior is associated with more morbidity.
Anything else you would like to decide? A very practical thing. If you see the curves in the skin, the skin is so much folded. I think the patient may be obese. How is the patient? Is the patient very obese?
Yes, sir. He was.
Yeah. So if the patient is very obese, I won't like to do a posterior surgery. An anterior surgery may be much more easier for me. So if you put it this kind of patient posterior, in a prone position, you open up posteriorly, there could be multiple problems. So you could have some compression over the chest. There could be problems with ventilation, and some things. One of the things which people actually undermine, don't actually pay attention, is good skin opposition. So if you have a lot of curves and creases in the neck, you may not be able to achieve good skin opposition, and even post-op dressing may be an issue. The patient lies supine, and on the second day you'll find that there is a leak over there. So sometimes it's very, very difficult. So in really obese patients, I would prefer as anterior approach, even though it's 3 levels. It would be still a minor surgery as compared to posterior surgery.
Okay.
Sir, you would like to
But
point
again,
something out?
these are all your opinions,
Yes.
So when you voice out your opinions, you have to kind of try to put it out in a very logical manner.
Yeah, back it with logic, your logic. What about a laminoplasty? Aren't you interested in laminoplasty here?
So there are some OLF buckling of the ligamentum flavum can be seen, which we won't be able to remove in a laminoplasty. So
But you will be creating space, no? You will be lifting off the lamina.
Yes, we can do a laminoplasty.
So basically, this answer is very easy, that I am well versed with and I would like to offer. So I am more confident of doing laminoplasty. I have learned laminoplasty in my center or something like that. That also can be an answer for this question, I believe.
Any specific disadvantage of laminoplasty?
So the ossification can happen again. Because
What is the commonest side effect of laminoplasty?
Does it cause pain anywhere?
facile.
Neck pain, no? Neck pain is the commonest complication or side effect or whatever of laminoplasty. So once again, if you're hanging on to laminectomy, that's totally fine. But you need to then iron out why you're not up for fusion, why you're not up for laminoplasty, and why you're not up for anterior. You should have a very clear mindset, and then you're fine, because in any case you can do anything. So you should know why you're not doing this and why you're not backing, A, X, Y, Z.
Yes.
So Subhranshu, one point, if you ask me against laminoplasty here, is that there is a huge anterior compression, which ideally deserves an anterior surgery. Now because of reasons of multiple, or whether it is badly calcified, you are opting for a posterior surgery to create more space so that the cord can translate backwards. Now in laminoplasty, there will not be so much of space created. There will be still lamina behind the cord, and it will stop it from coming back. Second is that this compression is at the extreme of the curve. The cord will translate maximum in the center, which is at the C5-6 level. So if you try to do a laminoplasty, the chances are that you may not be able to decompress the cord adequately at the upper level, which is the C3-4 level, where there is a huge anterior, whether you call it a giant calcified disc, or you call it a osteo disc complex, or you call it OPLL, but you will not be able to decompress it adequately with laminoplasty. So I would not think of laminoplasty in this situation, at least in this patient.
Right.
What's the incidence of C5 palsy in a laminectomy?
Around, I don't know, sir, around 30%.
30%?
30?
Are there any risk factors that you can predict C5 palsy preoperatively? Are there any measures that you know definitely avoid a C5 palsy? Intraoperative measures that you take, any steps you take? So the only known predictor as far as I know is a myelomalacia at the level of C5. If there's a myelomalacia preoperatively level of C5, they're known to have a higher incidence of C5 palsy. No other indicators are known. Agnivesh, Sarat, you all can come in here. And there's nothing you can do intraop specifically. Lots of things have been described, but nothing that has specifically worked. What is your take on nerve root release? You do foraminotomy at C5 preemptively. You think that will help the patient not get C5 palsy?
No, sir. It is mainly due to a traction injury.
So if I do a foraminotomy, I'm releasing that root, no?
There is increased chances of injuring the nerve also while doing the decompression.
Yeah, I mean, statistically, it's not shown to help, though, the idea was right. So the two reasons why they say it may not have help in statistics is because you're causing injury while doing the decompression, and you're actually facilitating posterior shift of the root because you're actually uncovering the roof. So, Sharad, any inputs here?
Yeah, it's a very dicey thing. Nobody actually knows how to prevent it. I agree with whatever you have said. I don't have any other things to add.
Perfect. Agnivesh? Otherwise, I think it's a wrap. Anything else anyone wants to say? I think we are pretty much on the ball. So, Banshu, you're quite good. So I think the short message from me is that you should be able to keep talking, keep replying with less pauses, and talk on a straight and narrow path. Speak what you know and avoid speaking what you don't know. So get into a conversation on subjects that you know, and hang on to things that you'll be able to discuss. The minute you bring out some word that is unfamiliar, you're going to get pinned in. So I think the trick of the exam is to give the examiner the confidence that you're leading him on. Sarat, your inputs?
I think you covered it quite well. Most of the things, whatever you have covered, are quite okay. Only thing is, there's no point mentioning so much about negative history. Just mention the relative negative history. And most of our residents, we ask all our residents to use the 4-pronged strategy while making a diagnosis, both for the history as well as for examination. So you could do that. Only issue is if the examiner is not very comfortable with that, he may oppose it. But we do that 4-pronged strategy. We do it regularly for all the neurological examinations. But otherwise, I think you presented fairly very well. Your discussion was also quite okay.
Lovely. Agnivesh, your inputs?
No, sir, he was very good. I think he has done an excellent job. And Sarat sir said very valid points. And what your points are the same. I am also going to tell you the same thing, that don't put your foot sort of at a place where you sort of don't know where you are treading into. So just stay focused and stay where you know, and leave something for the examiner to ask. Lead him to ask you the questions what you know. So subconsciously you have to lead him to asking you the questions what you know better, rather than sort of catching you here and there.
Great. So before Harshal takes over, I want to personally thank both Sarat and Agnivesh for taking out time, because this is of immense help. You can't imagine how much help it is to all the exam going students who are watching, because it gives a lot of confidence to have two unfamiliar people with a lot of knowledge, pinning them down and them, bouncing questions onto them. And we've all been through it. So I think, you've done great service to, do this course. So thank you for taking out the time. Harshal, over to you.
Thank you, sir. I would really like to thank Sarat sir for spending 2 hours with us, spreading all this knowledge, because we always feel that we have a little bit of shorthand when it comes to all these trigeminal nuclei and the spinal accessories and all these things. So thank you so much, sir, for giving your inputs and spending 2 hours here with us. Agni sir and Abhay sir, we are going to be in-house. I think next few sessions also you'll be there. And I would like to invite Shyam sir again if he's free. And Subhanshu, masters have spoken. You've really done well. So thank you so much. The next session is on next Friday. We are going to have a long case again. We'll have some new face presenting a long case, and we'll have Dr. K.V. Menon also joining us for the next session, as well as Kshitij Chaudhary sir.
We have
and
a
I'll update all the
scoliosis
details.
case next
Friday. Next Friday is AIS case, sir. Yes.
So we can give Sharat a break, I think. Poor guy.
Yeah. No, we'll get him
back
for
on one of the cervical radiculopathies, maybe.
C1, C2s, yeah. Whether it's cervical radiculopathy or something like that, we'll get him.
Yeah.
We'll be happy to host you, sir, again. Thank you.
Thank you, sir.
Thank you, Agnivesh. Thank you, sir.
Thank you very much. Bye-bye.